Hello and welcome to Paying for Healthcare in America. This is Chapter 7 of the Cherry Book. My name is Jason Goodwin. I'm one of the professors for Nursing 437. We're going to get right into this. We'll talk a little bit about one of the things that I'm really excited to teach you, believe it or not, is healthcare finance. Okay, so question number 1, the 1983 revolution in healthcare insurance reimbursement that formed the primary method of reimbursement in today's healthcare system. So what's the revolution that brought us to today's reimbursement? Was it the inferior care provided by managed care organizations, rapidly rising healthcare costs, technological advances that increased the cost of healthcare, the change from a prospective to a retrospective payment system? Those are the 4 options you have, and we'll try to make sure that we can answer that by the end of the slides. Okay, so talking a little bit about how everything began. In the 20th century, healthcare was very different. Physicians had the dominant role in healthcare, as they do in some ways today, but all decisions related to finances were driven by physicians. They controlled all access to healthcare services. Tests and procedures were provided solely by if they determined that there were any marginal benefit to be obtained. So in other words, if there was anything to be improved for the patient, regardless of cost, that's what would be spent on that. And many of the physicians were proprietors of healthcare facilities, so they prescribed the care and then also owned the facilities that provided it. And as I said, the best possible care to everyone, regardless of the cost, was the mantra from the time. Then we went to a retrospective payment system. We had a fee-for-service payment method and economic incentives that contributed to increased costs. So what we had was a situation where the more tests that you ordered and the more procedures performed, the more the clinicians earned, right? So as you can probably guess, there was a whole lot of incentive for someone to decide that, if they wanted to, that they could order more tests to make more money. Patients were insulated from this cost because at that time, if a physician ordered it, the insurance company paid it, right? And so in that way, the insurance company was actually perpetuating the incentive to increase costs as well. As I said, there's incentives to use more of the services because there's no restrictions on it and no scrutiny as to why it's being used. And that was back to where the safety net was oftentimes the county hospitals, and those were more common to be used. So let's talk a little bit about, did the lack of cost consciousness contribute to increased costs? So the questions asked, were the patients aware of costs? No, and in many ways they're still not today. We'll talk a little bit about that. Were providers aware of costs? Not in general. There were some cases where there was a general idea that something was expensive and something wasn't. But in general, they didn't need to concern themselves with that because that wasn't part of their purview. In some ways, we'll talk a little bit about later, that is a battle that we're still fighting today and might provide some answers for reduced costs. Did providers receive more income for using more services? Yes, that's the way the system was set up, and that's why there was nothing preventing that from happening. And did providers incur financial risk for using additional resources? Not really. And so there was no real problem with ordering too many or ordering excessive procedures for what needed to be done. I'm sure there were plenty of people that stuck by by what was just necessary for the patient, but the incentive was there, and consequently, incrementally, that grew over time. Okay, Medicare. In 1965, our government established a fee-for-service payment system. And so this started originally, it was created for people that paid into Social Security and also for people that were working for the railroad system at the time, which provided a really good railroad pension program. if you're doing your taxes, keep an eye out for it the next time. There will be a couple questions on whether you're on a railroad pension, because even today there are government carve-outs and subsidies based on tax credits and things like that if you were involved in that. Medicare is the largest payer of hospital expenses, and so there's a huge pool of people that are covered by Medicare. So we'll talk a little bit about the specifics of that. They drove the rapid growth of expenditures. So because this payment system was in place and because it was largely unchecked, the Medicare system would just pay these checks when they came through. It was a retrospective payment system, and they would pay whatever was done. There was no review before the decision was made. It was just kind of like, oh, you used that? Okay, we'll write you a check right now. As you can guess, that drove a rapid growth of expenditures and quickly became a major factor and something that we noticed in our federal budget. So we're going to get specific here a little bit. I'm going to talk about some things that hopefully don't bore too many people. If you watch the news or if you have any interest in finance, you may hear our gross domestic product described in the U.S. Okay. So essentially, it's the value of goods produced plus the value of goods and services imported minus whatever's exported, right? So you hear a lot about people saying, we want to export as much as we can, we want to import as much as we can. Essentially, the gross domestic product, to put it in a simplified way, is like a family's income, right? It's the amount of money that you make in a specified amount of time. And so if you think about it that way, that's sort of what our country as a whole produces and earns. And so what we'll talk a little bit about later is the expense side, and it's important to understand both sides of that, and it'll give you context. So to give you context, the U.S. healthcare in 2019, our GDP, what we spent for U.S. healthcare was 17.7% of our GDP. And so there are countries that have more. We'll talk a little bit about that. But just to give you some more context, because you'll hear a little bit about budgets and things like that nationally. And so 3.8 trillion is what we spend annually on our healthcare in the United States. We're the second most in the world by percentage of GDP in 2018, the second most expensive. By the same terms, Israel is at 7.52% of GDP, and Canada is at 10%, despite having a nationalized healthcare system, which you would assume is more expensive, right? So a very expensive system. We'll talk a little bit about why that is. Okay, going a little bit more into the history. Medicare, they went from a prospective payment system they went to a prospective payment system, and that's based on diagnosis-related groups. So instead of saying, okay, you used X for this procedure and we're going to write you a check, they went to an idea of, okay, this group of diagnoses, you're going to earn this amount of money for that, right? So they started using those types of strategies, and what happened was it limited the total payment to a hospital to an amount that's already been agreed to and is based on research and more sensible payments. It took away the blank check effect. And so since Medicare is the largest single payer of hospital charges, this began a critical shift for the hospitals in how they began to manage the decisions being made and how physicians did as well. Now, what this created is sort of a new importance in the hospital, people that would facilitate this work. So there were administrative staff, business managers, coders, nurse utilization managers, claims referral people, and today you'll see those people still working on how to manage the business side of all of this care, because like they say in some places, if there's no margin, there's no mission, right? You have to keep the doors open in order to help patients. So, and you'll see things, reimbursement codes thrown around like ICD-10, CPT codes, HCPA codes, which are HCPCS, So you'll hear those things being discussed, and that's all part of the prospective payment system that we have today. The reimbursement revolution. So as this began, private insurance companies initiated similar reimbursement arrangements. So they started emulating what Medicare was doing because they liked the cost containment aspect of it, and it seemed to not grossly deteriorate care. And in fact, insurance companies have followed in that manner the governmental programs, Medicare and Medicaid, since then. So a lot of times those programs will come out with something and then the insurance companies will follow suit. Medicare extended the financing revolution to physician reimbursement. So this started to bleed into how physicians are paid. They initiated the resource-based value scale, which sort of went to this idea of revenue-based units. And so physicians billed based on some of their work, and they started having to specify what was being done. They brought the physician reimbursement more in line with the skills required and the actual time spent on the procedures. And it's similar to what you'll see today. And then the invention of managed care. The managed care companies came in, and this was sort of the next generation of some of these cost containment ideas. And so you had HMOs, so that's a health maintenance organization. And then you had PPOs, which is a preferred provider organization. They had insurance companies, a peer review organization, or sort of another review mechanism, evaluated the patient's options, and then made intuitive decisions based on actual data and pre-specified algorithms to come up with acceptable decisions made around care. This slowed the rate of growth of healthcare costs as well. But it also spurred a lot of discussion and complaint, and it's happened since it began and it continues today, is the ethical question of, where is too much, right? How much is cost containment worth discussing in healthcare, and how much is it ethically a problem to start to think about how to reduce the cost of someone's healthcare? Well, since our gross domestic product, as we talked about earlier, we're 17% of the expenditures of our entire gross domestic product on healthcare, we have to start asking those questions. And we'll talk a little bit about medical inflation and how that contributes to it as well. Okay, inflation and cost containment. So, in the 70s and 80s, healthcare costs increased more rapidly than the prices of most goods or services. When I was in nursing school around the year 2000, the medical inflation rate in this country was somewhere around 10 to 15%. Now, for those of you that have an interest in inflation or maybe investments, things like that, if you keep in mind what the inflation rate is in this country, which is essentially 3 to 4% on any given year, if your medical inflation costs are 15%, obviously year over year, medical costs are going to be more expensive, and eventually that's an unsustainable situation for American citizens. So that's the conundrum that we're in. Measures have been taken in recent years by insurers, payers, providers, and even consumers to slow this healthcare inflation. And in fact, resulting in 2019, the medical inflation rate was 4.6%. Now keep in mind that's still above the 3% that inflation is typically at in this country. So it's still growing faster than the rate of inflation, and that continues to be a problem. If any of you have seen what the non-subsidized and non-employed are having to pay for insurance in this country, some of them are paying well over $1,500 a month. Okay, so the largest share of healthcare expenditures for hospital-based care, right? We're talking about DRGs. They reduced hospital admission rates and patient average length of stay. Okay, So what they started doing is they started saying, okay, how can we keep people out of the hospital because it's the most expensive aspect of care? How can we reduce patients that are in the hospital's length of stay? How can patients be discharged, quicker, and how can we discharge them a little bit earlier than we've typically thought of? And then that sort of spurred the idea of home health care and primary care clinics. And that was the beginning of the idea that, we can start prevention and we can do other things to limit the cost of care. And they had to do that because at the end of the day, they were only going to get so much for each procedure. And hospitals are using that today. They're using cost-cutting techniques. They're minimizing the amount of inventory that's kept, just-in-time purchasing you might hear. They join purchasing groups like Medline. You may have seen that company. They're using physician review on certain medical decisions. Medicare, which we'll talk a little bit about later, has instituted a quality-based pay for performance aspect, and so the better the hospital actually does, the more they can potentially get reimbursed. And the opposite, if they're not holding up their end of the bargain on that, then they may actually be penalized. And then you may hear things like value-based purchasing. So committees that are actually making the decisions on purchases. For a while, I did that work for one of the local health systems here. We set up organizations and infrastructure in each facilities in the region to make sure that these decisions were being made. These were surgical decisions. They were being made with all of the pieces of the puzzle, not just this is the nicest new toy, but how does it relate to actual outcomes, and is there similar technology that has similar outcomes that can also be considered that might be worth less expense. Also, one more thing of note is the invention or the advent of the idea that physicians and hospitals can develop joint ventures into cost-sharing agreements. And so you'll see things like this. Insurance companies will have, blue star programs where if a physician and a hospital are in an arrangement and they can achieve certain quality levels, the reimbursement from the insurance company will increase, and they'll also become a preferred provider for that total knee replacement, for instance. So it's really changing the way things are happening, and all of it's based around the improvement of quality and some of the metrics. So you'll hear about that when you do, but it's for the first time, it's an exciting time to see hospitals and physicians on the same page with those decisions. And drug companies haven't been immune to this. They've been, in some ways, forced to limit price hikes. Generic products are used more. If you pay attention to the media, though, you'll see that there, as recently as this year, there have been problems with, epinephrine costing thousands of dollars, or a cancer-curing drug that was inflated, 10,000%. So it's a big problem, the regulation of the pharmaceutical industry, and I think that's heavy on the minds of many regulators right now. And there's new cost containment and utilization strategies under managed care that have helped slow this, and it's certainly on everybody's menu for discussion, but it's a major driver as well in healthcare costs. Okay, so a little bit of a discussion on where to go from here, right? So American healthcare, we know it's expensive. We know there's high technology, and we know actually in some cases we spend money on things that don't actually have an outcome-based value judgment on it. So what's the perspective of our population? What do we do? Is it access to care that we value? Is it universal care, which may help all people, but may not have the same development of access depending on how it's organized? In this country right now, with the Affordable Health Care Act, we have everybody in this country has the ability to sign up for subsidized care if they need it, depending on their incomes. But everybody has access to that. Now, does that mean that every patient is able to access services? No. And so when you hear access to care, it's about how can we facilitate our systems to make sure that we get out and encourage the most useful time with patients to help promote their health. And that's where health promotion comes in. A lot of people don't want to go to universal health care because they see it as a new social program. And some people think, well, a single-payer universal system will highly streamline our process, and they think that it will improve the systems. And there are some proofs of concept with this. Other countries like Canada, France, and EU all have universal health care. And in fact, as I said before, Canada does that with 10% of their GDP, which is less than what we spend. So there has been a lot of debate over the years. Not an easy solution, but there are some examples out there of what to talk about. Access issues. We talked about figuring out why people can't access health. So it's due to patients not being able to access insurance, but that doesn't mean that they're not able to get it, right? But somebody that's living in the Appalachian Mountains, for instance, or they're homeless living in an area of a demographic area where there's not access to care, a socioeconomic section of the population that are less likely to access care because of certain things that might be barriers, right? So what we do is all about trying to figure out why the patient doesn't have access and remove that barrier. And that's why you see things like community clinics, immunization clinics, primary care clinics, ambulatory care, urgent care, right? These are all subdivisions of how to streamline access so that the critical services like acute care hospitals or trauma centers aren't bombarded with people that don't have access any other way. Because many times what happens is, if you don't have yourself a primary care physician and you're not comfortable with navigating the healthcare system and you don't have an advocate, what's going to happen is you're going to wait and you're going to have whatever diseases you have. Maybe you have diabetes, maybe you have some other lifestyle modifiable diseases, but you're not going to do anything necessarily to prevent that, right? And so eventually one day will come when I haven't really worked on preventing these things, but I have a heart attack and I'll go into the emergency room. Or maybe it's not a critical situation. Maybe I have a really bad flu symptoms. Maybe I have pneumonia. I'm going to go to the emergency room. Or maybe I have a major problem with an antibiotic. That could be handled in a primary care clinic, but I'm going to go to the emergency room. So decanting the emergency room is a huge help for our health system too, right? As well as ICUs and the rest of the hospital. Okay, so in 2002, 15% of our population was uninsured. In 2010, the Affordable Care Act came in. In 2012, there were still 16.3% uninsured, but that's when the clearinghouses came in, and in California, for instance, we have Covered California, right? But that doesn't mean that everybody has signed up for those things, and many people still do not have care. So, that's what you hear about when you say uninsured, and all of those things really could be called unable to access for whatever reason, right? And that's the point, right, is getting them into care as soon as possible. Long waiting lines to obtain care equal lost wages, right? So this does have a macro effect on our economy. If we can efficiently care for the people that need it in the best place to do it, then we're maximizing our ability to take care of our population, which is in and of itself an efficient way to maintain care, which is low cost, right? So there's value there in just doing our job right and making our system support that. Let's see. So uninsured and underinsured generate uncompensated care, aka bad debt. So how this works is that you have things like Medicare, right? And so Medicare is the largest payer of revenue for our hospitals in the country. And it's the largest by amount. It's also the largest by number of people signed up. Now, revenue is not profit, right? So it's the amount of money that a hospital takes in. But for instance, so 80% of a hospital's profits are made from their surgical department, right? So what happens is the emergency room, for instance, performs an extremely important part of the mission of our patients and of the hospital. But there's a large percentage of their patients that actually aren't going to reimburse the hospital what the care is worth. So we actually would lose money in that situation, right? But there are other services that pay, more to the hospital for those procedures, and there's a sort of a bad debt compensation. So hospitals actually make their money and stay profitable by subsidizing care that doesn't pay them enough money, but also making improvements in care that can reimburse them so that they're profitable. The problem with that is that the incentive is on finding service lines that are profitable versus what's not profitable, right? And that doesn't happen very often, but you'll hear about it in the news every once in a while, an organization that's gone a little bit awry and they've ignored some of their lower cost or lower reimbursing service lines and gone towards more expensive ones. Resource allocation. So questions to be asked, okay, what combination of medical goods and other goods and services do we want to produce, right? So these are all questions that can be asked on a more of a macro scale in the United States, but it also can be asked within healthcare. What types of service lines do we want to provide? Should we have an open heart program if there's an open heart program across town? Are we doing that because the reimbursement is high? Are our underserved populations being taken care of? So are we making our decisions based on the right ethical reasons, or are we trying to make financial decisions based on profitability, right? That's the struggle. What type of health and medical care do we want to produce, right? Are we going to be interested in technology as a country moving forward? Is that what's most important to us, or is value most important to us? Are we focused on crisis-oriented care? So are we going to spend our time covering up for the disasters and the last-minute things, or are we going to focus on preventing, right? You've seen some of this come forward in the last few years with organizations, preventative care like Kaiser Permanente, and all organizations now are moving towards that. What's happening with preventative care? So what is happening now is that not only Kaiser, but all organizations are working with places like the Institute for Healthcare Improvement, the World Health Organization, Joint Commission, the Center for Medicare and Medicaid. They all have recommendations. Medicare reimbursement is based on things like avoiding never events, which are preventable events that happen in hospitals that healthcare organizations aren't reimbursed for. So they're shifting incentives so that the right quality measures can equate to financial reimbursement and ultimately viability. So that's a real positive, in my opinion, on where we're going. Who should receive healthcare goods and services? Are we interested in getting everybody served or protected in this country? Or are we interested in trying to, and is that enough, or are we trying to get everybody actually treated? So those are all things that we're trying to work out as a country. Economic approaches to healthcare. So the U.S. healthcare system is a regulated market, right? We talked a little bit about this before. You have the Center for Medicare and Medicaid. You have Joint Commission. You have, as I said down here, the California Department of Health, right? And so there are plenty of organizations that are telling us what we have to do, what the requirements are for quality, and all of that is very positive in nature because it protects our patients. There are also, the other side of that coin is it can sometimes become so oppressive that it can restrict a real free market in healthcare, right? And healthcare is not a free market in the United States; it's a regulated market, and that's worked very well for the safety of our patients. But it does create a lot of inefficiencies in our market. But it does. Legislation and regulation has been really important in areas like requirements of minimum nurse staffing ratios at hospitals, laws requiring disposal of medical waste products. As I said before, things like never events, right? Like central line blood-related infections, surgical site infections, retained surgical items. So those are all things that are reported and tracked and also have to do with reimbursement. As I was saying before, we're not a free market here because, in a free market being, a completely uninterrupted economic system, right? A capitalistic system. That's not what we have here because there are many other ideas at play that make it not truly a competitive environment. One of them is subsidization, right? So we subsidize certain areas of our market because we don't want the fact that they're not profitable to affect the fact that we still need to provide it, right? You have critical access care hospitals that they may not be as profitable as the private hospital down the road, but they can't fail. So there's a public commitment to making sure that they have a different mission, and that's fine. But that's not part of a true market where the survival of the fittest, because we can't allow that in our system. Physicians can be in charge of making decisions about what services can be, what the patient needs. That's another reason why it's not truly a free market system. Physician reimbursement incentives can still encourage over or underutilization of services. It's difficult to get information about prices of services. So in this country, price transparency is something that is only recently becoming more discussed. And you may even see surgeries online that you can look up and they'll tell you how much they are. And so that's something that would never have been communicated. There are good organizations and websites. One of them is called Hospital Compare, where you can go on there and actually see what some of these different hospitals, how they rate in their care, what it costs for different procedures. And that's becoming more and more common. One of the reasons that has been is the average expense per person annually. In 1965, it was $202 per person, right? And so in 2019, it's almost $12,000. So as I said, that's approaching a house payment, right? And so there's not a lot of people in this country that can afford all of the things like housing, like medical care, and then still be able to afford to pay their bills. So eventually that becomes unsustainable for a very large percentage of the population, and that's when it becomes unsustainable. And then, keep this in mind, right? We've talked a lot about how expensive U.S. care is, but U.S. is actually 51st in infant mortality rate. So out of 227 countries, we're 175th or something like that. So that means we have 51 countries that have a lower infant death rate. And so that's used in a lot of cases to review how we're doing in overall care, and it's usually used as sort of a benchmark. And so the takeaway from that is, are we expensive? Yes. And are we the absolute, do we spend money on technology? A lot. And are we the absolute best? No. So that's a real ethical dilemma that's been discussed forever. Sources of healthcare financing, private insurance. So how much does it pay? So talking a little bit about PPOs. So the PPO is a preferred provider organization, and you may have encountered this in your own healthcare, but what you'll see is that in a PPO, I'm able to reach a more specialized physician a little bit easier for that, right? And so I might have a preferred guy that I use, but I don't need to be referred from a primary care physician necessarily, or I may have access to specialists without referral, and I'm going to pay a little bit more on that, and that's something that the consumer decides or the patient decides that they want to pay for. Then you have a health maintenance organization like Kaiser Permanente, and by the way, the PPOs, an example of that would be Blue Cross Blue Shield PPO. An example of an HMO is Kaiser Permanente. Most of us know that in this area particularly, they started in the Bay Area in the I believe the 60s as a union actually for the shipbuilders, and so that health plan was born of that idea, and because of that they developed a sort of a completely unique approach to how to make money in healthcare, and that was based on the idea that they could prevent catastrophic care, and so they understood early that that was the most expensive part of healthcare, and so they capitalized on that early, and they essentially, in many ways revolutionized the healthcare industry before anyone was doing that. But an interesting fact is that in the earlier, maybe 60s, 70s, and 80s, many of the physicians that worked for Kaiser were blackballed, ridiculed, and really ostracized because they would dare work in a countercultural medical environment. So that just gives you a contrast on how things have changed today. Okay, so public insurance, so then you get into the Veterans Affairs Organization, you get into Medicare and Medicaid. Those are the public insurance, and these are the payers that we talked about earlier that are a very large chunk of patients in this country, very large amount overall because of all the people that have it, but a low reimbursement comparatively to some of the other private insurances. So there's the conundrum of hospitals, right, which is this is a larger percentage of what I need. They're generally sicker, and they need the care probably in some ways the most, but they're the ones that I have to compensate for with other high-end services in order to keep my doors open. So that's the hospital administrator's conundrum. So impacts of payment modes. So all of these different changes, they increase the efficiency and delivery of care, and they influence provider behavior, right? And they talk about incentives, shift towards cost-effective methods of care, and we're going to talk about that. So the effectiveness of care. So how, you're probably sitting here thinking as a nurse, how the heck am I going to influence these things, right? Unless I become a manager 10 years from now, and maybe, some of you will. And there's probably, most of you are saying, I never want to do that, but you'll see. They'll make you. So how many nurses impact care how can nurses impact care delivery? So nurses have always had a unique ability to connect with the patient. They've always had a unique ability to make good decisions based on the best care for the patient. They haven't always had access, as have doctors, they haven't always had access to the information about there are decisions that can be made, right? So there are organizations out there with physicians and nurses that are creating more transparency towards, this versus that. And I personally have done this work and have seen with nurses that I've worked with, if they understand that this procedure tray, if they're not carefully selecting what they use, for instance, it costs a lot more than what they could use. They're respectful enough, not only for the patient, but for the system to say, this isn't good for the whole, and I'm not going to use that one. I will make a different decision based on the knowledge that I have, right? So those are the things that are happening a lot, and that's how you can affect the care. Coordinating care, creating systems as a nurse that are that limit waste, right? Like things like home care, outpatient clinics, ambulatory care. They were all created to create a more efficient care environment. Case management, some of you may work in that area at some point, and that's a person that it's your job to find opportunities to reduce waste and save unnecessary waste in financial waste. Okay, so what are we going to do, right? What's the next step? Disease management. Are we going to use preventative care to improve the health status of a defined group? It seems like that's where we're going. Is it about outcome management? I think so. We have to understand what the result is of what we're ordering. Otherwise, we're back in the day where we just did what we thought was best, right? And now we have things like data, and we have policy changes that are starting to understand how to bend this needle down. An example of that is, there's a really good book out there. It's a bit outdated by now, but Healthcare Reform Now was written by George Halverson, who used to be the CEO of Kaiser Permanente. He was probably 2015 or so, 13. And he wrote this, in this book, he made the really revolutionary claim that if we took the 5 most, there are 5 diseases that account for 90% of all expenses in healthcare, and that's congestive heart failure, diabetes, high blood pressure, coronary artery disease, and cancer. And what he said was, if we were able to manage all of those items very closely, we could reduce our expenses by up to 90%, right? So that was obviously got a lot of attention, right? And I believe that there's some truth there. And Kaiser Permanente has proven that if you can focus on some of those diseases and make really good pushes towards quality, as they have with blood pressure management, diabetes management, right? Some of those things can really affect your financial bottom line and also, improve the patient's health. So it's a win-win. What George Halverson didn't note in that book, however, is the fact that 30% of overall healthcare expenses in this country are based on labor costs. And so that's the other discussion that really hasn't hit yet is, what do we pay doctors and nurses in this country, and how does that contribute to the overall, right? And that's going to be an interesting conversation in the next 20 years as well, but I think it's going to have to be thought of because it's a large percentage of what we're trying to figure out how to do the best. Okay, so we talked about technology. So what we have coming up is we have the opportunity to use new technology to improve our care, right? We have technology with Epic. Many of you have used electronic charting, Cerner, Epic, things like that. Many of those programs have data mining capabilities, and you can use that in many ways similar to the big data sector, and we can make judgments based on real data. Clinicians can make that in a scenario where we know the outcome will be improved. So that's a really fantastic thing that we have coming. From the consumer end, we're trying to work on prevention. A lot of that has to do with education, right? What are the reasons why you're not ready to lose weight, or is there an innovative way to teach someone how to practice a health promotion technique that actually improves their life, right? And does that turn into something really special? And then we have things like price transparency, which are going to be coming and really have an important factor to play. Okay, so going back to, this is a question, right? Which nursing activity models health promotion and preventative care to achieve effectiveness of healthcare resources? So let's break this question down. Which nursing activity models health promotion and preventative care? So explaining blood sugar levels, that's something we do. Encouraging the use of salt substitutes, also. Encouraging appropriate use of pain-relieving strategies, again. Educating on smoking cessation. Well, when you're looking at a nursing activity, the education on smoking cessation is sort of a specified procedure. It's something that nurses do as part of their activities. And finally, going back to our first question, the 1983 revolution in healthcare insurance. And we've been talking about for the going from the payment of whatever happened, whatever procedures were done, to payment based on some agreed upon guidelines. The primary method of reimbursement in today's healthcare system was due to A, the inferior care provided by managed care organizations, B, rapidly rising healthcare costs, C, technological advances in increased the cost of healthcare, or D, the change from a prospective to a retrospective payment system. So D is, we know D is not right because we changed from a retrospective to a prospective system. So that doesn't make sense. The technological advances that increase the cost of care, well, that's certainly a possibility, right? Technological advances do that, but that has nothing to do with the revolution of what happened. And then the inferior care caused by managed care organizations, I wouldn't go that far. I think the best answer is rapidly rising healthcare costs, or B. And with that, we've concluded our lecture. If you have any questions, please feel free to post your questions. Don't forget to like and subscribe. I'm just kidding. That's what my kids say all the time. It's been nice talking to you guys, and I'll see you soon.